Dear colleagues, my name is Elaaha Anwari. I'm a resident doctor at Charité, and I also work in our core lab, where a lot of our work is around intravascular imaging and acute coronary syndromes. Originally, Dr. Abdel Wahed was supposed to be here today, but he's unfortunately stuck in the clinic, so I have the honor and also a little bit of the stress of giving this talk instead. I know that many pioneers that have actually shaped this field I'm going to talk about are sitting in this room, so I try my best. And with that, let's go straight to the point. This is a patient we all know, a 76-year-old patient that presents with sudden chest pain that radiates to the left arm. The ECG shows ST elevation in the inferolateral leads. Everyone moves fast, and we go straight to the cath lab. On the angiogram, you see here the circumflex artery is markedly aneurysmatic, more than 6 millimeters and completely packed with thrombus proximally. Distally, the vessel looks quite normal. So our first impression, and I think most of us would have thought the same, was, okay, the culprit lesion must be in the proximal lesion inside the big aneurysmatic segment. That's where everything's happening. The problem is we don't have appropriate stent sizes to stent this aneurysmatic segment. So our plan was very pragmatic, to do some thrombus aspiration, some gentle balloon dilatation, maybe give a GP2B3A inhibitor, and then discuss the next step in our heart team. Once we had a reasonable TIMI flow, we decided to take a closer look with OCT, mainly to understand what's clearly happening there. And this is where the story really changes. In OCT, we suddenly see that the actual culprit lesion is not in the aneurysm at all. The plaque rupture is clearly located in the distal, at first impression, quite normal-looking, non-aneurysmatic part of the circumflex. What we initially thought was the culprit lesion inside the aneurysm turns out to be a secondary thrombus propagation from the distal rupture site. So this OCT finding completely changed our strategy. Instead of trying to stent the huge aneurysmatic segment, for which we had no appropriate stent size, we could focus our OCT on the true culprit lesion. So guided by OCT, we implanted two drug-eluting stents with a maximum diameter of 3.5 millimeters and did not stent an aneurysm. The final angiogram showed an excellent result. Here on the right, you can see a follow-up, at 8-week follow-up angiography. For me, this case is a very nice illustration of what we mean with pathophysiology-based PCI. OCT helped us to distinguish the true culprit lesion from a secondary thrombus and avoid unnecessary interventions. So this plaque rupture has occurred as the consequence of a vulnerable plaque. We already heard a lot about vulnerable plaques, also from Professor Jona, who explained the pathophysiology, histopathology behind that. But before we actually reached the point and had OCT, we had histology. But we cannot do histology on living patients, and that's exactly why we need in vivo imaging. So how does OCT actually work? That's very basic for many of you. So OCT is basically light that goes through the vessel wall. Lipid absorbs the light and appears dark, but fibrous tissue, on the other hand, reflects the light, so the fibrous cap appears bright. And because of the high resolution of OCT, we can actually measure this cap thickness in micrometers. That's one of the key criteria of a vulnerable plaque. We say that the fibrous cap is under 65 micrometers. But OCT doesn't stop here. We can also look at many details of plaque vulnerability. For example, macrophage accumulation, microchannels, spotty calcium, and other structures. NIRS looks at the problem from a different angle. NIRS doesn't care so much about CAB, it cares so much how much lipid we have. It gives us the lipid core burden index. If that value is high, we know the segment is very lipid-rich, which is also one important feature of a vulnerable plaque. And then we have IVUS, which again sees something else. It shows us plaque burden and remodeling. The next step is when we detected it, we can treat it, but better than detect and to prevent it. And therefore, PREVENT studies is a good example. Vulnerable non-flow limiting lesions were detected with imaging and then treated preemptively. At the same time, other studies like Pacman AMI showed us that we can also change vulnerability biologically with high-dose statins or PCSK9 inhibitors. We can thicken the fibrous cap, shrink the plaque, and reduce lipid content. And finally, for this audience, we have heard it already, we have the concept of DCBs, like in the debut LRP trial, where lipid-rich plaques are treated locally without leaving a stent behind. Before we talk about our own data at Charité, I'd like to show you the different pathophysiology of ACS. We can look on OCT. On the left, we see the classic plaque rupture. This is what happens when a vulnerable plaque finally breaks. It's still the most common mechanism of ACS, especially STEMI. Next to it, we see the plaque erosion, or we call it intact fibrous cap ACS. Here, the cap is thicker, remains intact. We don't see a rupture, but we still have a large thrombus that's sitting on the surface of the plaque. The third image shows a calcified nodule. You can see this irregular protruding calcium mass that disrupts the surface and extends into the lumen. And on the right, we have a spontaneous coronary artery dissection. Here we often don't see a typical atherosclerotic plaque at all. Instead, there is an intramural hematoma and a dissection plaque, which is compressing the true lumen from the outside. So now I want to come back from these big trials and general concepts to what we actually do in Berlin. At Charité, in our core lab, we are very much interested in those ACS patients in the pathophysiology. One of our main interests is the vulnerable plaque, not only to say this looks vulnerable, but to really understand why a plaque becomes unstable and what is really happening at the moment of the event. Optico ACS was a prospective, translational, multi-center study across the 3 Charité campuses. We included ACS patients, both STEMI and non-STEMI, and performed high-resolution OCT of the carpet lesion during PCI. Importantly, we didn't stop at imaging. We also performed intracoronary blood sampling at the carpet site to analyze local immune signatures. In the first analysis, we asked, do plaque ruptures and plaque erosion actually represent different biological entities? When we looked at the intracoronary blood, we found that IFC ACS lesions had a distinct enrichment of CD4 and CD8 T cells at the carpet site, compared with RFC ACS. So the immune microenvironment is very different, even within the same coronary artery. This suggests that plaque vulnerability is not only about how the lesion looks, but also about what kind of immune response surrounds it. In a second analysis, we asked a very simple question. If the plaque ruptures, where exactly does it break? We took the carpet lesion and analyzed them frame by frame on OCT. For each small segment, we labeled it as mainly lipid, mainly calcium, or a coexistence of lipid and calcium. What we found was that the actual rupture points were very often located in the segments where lipid and calcium coexist, not in the purely lipid and not in the purely calcified parts. Mechanically, that makes a lot of sense. Lipid increases the wall stress. The smaller spotty calcium behaves like a stress concentrator, and together they create a biomechanically fragile region where the fibrous cap is most likely to give away. So again, for a typical STEMI patient, we don't just say the plaque was vulnerable, we can now say where it was most fragile and why. So to sum up what I tried to show you today, first, our 76-year-old STEMI patient is not a special case. He's a very typical example of how a vulnerable plaque finally declares itself as a rupture with thrombus. The STEMI is just the last chapter of the story. Second, with intravascular imaging modalities like OCT, NIRS, and IVUS, we can move away from pure angiographic guessing. We can see the lipid, we can see the fibrous cap, the plaque burden, and perform pathophysiology-based PCI, like in our case. Third, we're not limited to just detecting vulnerability. We can also try to stabilize it with intensive lipid lowering on the systemic side and with targeted local treatment on the interventional side. Fourth, from our optical ACS work, we learned that ACS is not one disease. Rupture and erosion have different OCT pattern and different local immune signatures. And rupture often happens in specific hotspots where lipid and calcium coexist. And finally, looking ahead, I think the real opportunity is to use all this information together, morphology, biology, and mechanics, to carefully select which patient and which lesions do really benefit from a local therapy like a DCB. I like to end this, with a photo of our core lab working group at Charité. This is the team behind the projects I presented today. Thank you very much for your attention.